Thanks for joining us. I'm your host, Raquel Faria. I'm a doctor in internal medicine at the Centro Hospitalar Universitário do Porto. Today, I'm joined by Professors Maria Dall'Era and Murray Urowitz from the Lupus Academy Steering Committee, who will be providing expert insights from the key research and clinical data presented at the American College of Rheumatology, ACR, the annual meeting that was in November 2022. This year's meeting saw participants so eager to be together in person. Maria and Murray, welcome and thank you so much for joining us today.
Raquel, thank you so much. A pleasure for me to be here.
And thank you. It's a pleasure for me also to be here. Thank you for the kind invitation.
During the ACR meeting this year, we saw presentations of data from several clinical trials, including a new phase 3 trial of telitacicept with positive SRI4 response, updated data on the long-term benefit and safety of voclosporin of the Aurora trials extension, long-term safety of TULIP extension trials on anifrolumab, a phase 2 positive results of deucravacitinib, the phase 1b and 2 of zetomipzomib trial. These drugs are getting so much difficult to say. And a proof of concept CAR-T therapy in SLE. Murray, exciting times.
And congratulations on your pronunciations of these difficult new medicines.
I was trying to be there, but some stuttering. What do you think are the research highlights that mostly capture your attention?
So look, the first exciting thing for me in terms of the therapeutics was, oh my goodness, there are 4 or 5 drugs that are being talked about in the treatment of lupus, which is such a new thing for us. And that was very exciting. And you know, it was also exciting for the organizers because a number of these presentations were at the high presentation modes. Like there was one of the presentations was at a plenary session, and another was at a late breaking abstract. So even the organizers of the meeting thought these were important papers. So that was exciting. But I guess if you ask me what was the most exciting thing, I think we have to talk a little bit about, first of all, the most developed study. So that would really have to be telitacicept, and I think you'll come back to that. That was a positive phase 3 trial, and I sure would like to talk about that for a moment. And then the long-term follow-up on the established drugs that are now being used in many jurisdictions, voclosporin and anifrolumab, and we now have 3-year results on those. So those 3 things, the new drug phase 3 and the 2 long-term follow-ups, were very exciting. And then, of course, you mentioned the new mechanisms of actions like the deucravacitinib, the anti-TYK2 inhibitor, and the CAR-T cell treatments. These are sort of new approaches, which I think are interesting to talk about and give us hope for the future. So you can see I'm excited about all of this.
Maria, what were your most exciting moments of ACR in this research?
I agree completely with what Murray just stated. It was a very exciting ACR. I think what we realized coming out is that the pipeline of drug development in lupus is full of therapeutics that target different aspects of the immune system. And that's what's so interesting when you look at this, at the variety of agents that we're going to be talking about. They're very distinct in their mechanisms of action. And we know that the pathogenesis of lupus is complicated, involves aspects of the innate immune system, the adaptive immune system, and these agents target various aspects of those components, I think, in very nice ways. And as Murray said, I think what was very exciting was we gathered, we learned more data about established therapies. So, for example, the voclosporin blinded 2-year extension and the anifrolumab blinded 3-year extension. So more safety data, efficacy data there. But then we also garnered new data on these novel agents, as Marie recommended and talked about, the telitacicept, the proteasome inhibitor, the deucravacitinib, a variety of new agents, and the CAR T, which I think was also very exciting and created a lot of buzz at the meeting.
Yes. So we know that several clinical trials have failed on phase 3 before, when they did some expected good results on phase 2. So this deucravacitinib TYK2 phase 2 looks promising. And when we look at it and trying to do a parallel with the trials of baricitinib, that was a JAK inhibitor that also inhibits interferon signature, I kind of felt like, are we going to be so excited about this because it's an oral agent? And we're going to be disappointed as we were in baricitinib. Maria, what do you think that could be done in the trial and with the drug development that could give us more hope about it?
That's a great question, Raquel. And I think that is an issue that has plagued us in lupus drug development.
Yes.
Is that phase 2 results don't always translate into phase 3 results, right? And we have a trail of kind of disappointments of very promising agents, ustekinumab, baricitinib. There's a whole host of them that looked very promising in phase 2 and didn't translate to phase 3. And there are a whole host of reasons why we think that may be the case. We're hopeful in this case. We will see how the phase 3 pans out. Phase 3, as you know, is ongoing right now with deucravacitinib.
Yes.
I think, the mechanism of action is truly unique and exciting for lupus. And I think the way that this trial was designed, we learn from our past experiences. And so with each time we design a trial, we do better. We try to be more selective about the patient population, getting those steroids down as soon as possible so we don't have the confounding effect of high-dose steroids that will blunt any response that we might see with the active group. So that was done as well, trying to be selective about which sites participate in these trials, are these experienced sites. So all of those things are now, I think, being thought about more carefully going into phase 3. But I agree with you. We have cautious optimism, but we have to see how this plays out.
Murray, you are the most experienced person in lupus that's in this talk. Absolutely. And you have come a long way of disappointment also with the drugs. So the thing I wanted to ask you is...
There's no cause effect here.
Okay. And the thing I wanted to ask you is, we had a bad outcome on phase 3 ustekinumab, that is anti-interleukin 12-23. We had also disappointment with the baricitinib, that is anti-interferon also in the signaling. And now we have an inhibition in TYK that is supposed to inhibit interferon, interleukin 12 and 23. And we are still hoping. So we're not talking about the mechanisms that we think are positive. We're talking about trial design. So do you think that this is, for some patients, a mechanism of action? So despite the disappointments before?
Yeah, I do. I think Maria has really highlighted the importance here. First of all, this is a 48-week study. It's a long study. Yes. It's double-blind controlled. There are a lot of patients in the study. And the additional modification in this study is the steroid reduction, mandated steroid reduction that occurred. And despite that, long study, steroid reduction, the difference between, and remember, there were 3 doses in this study.
Yes.
It's very interesting that the primary outcome, the SRI-4, was accomplished in the 2 lower doses, the 3 milligram BID and the 6 milligram BID, but not in the 12 milligram BID. And then all the secondary outcomes, which again were outcomes which mirror the disease, the inflammatory disease in lupus, they were positive only for the 3 milligram. So that's, we've seen that in other studies that the lower dose is better than the higher dose. So that doesn't discourage me entirely. But if you look at the result, the difference between the patients and the placebo in the primary outcome was 58% response in the drug patients and 34% in the placebo group. So you're talking about a 20% difference. If you think about the early belimumab trials, which got passed, right? And so we can use that drug now. The difference between placebo and drug was 13 to 15%.
Yes.
And this one is over 20%. So, with the steroid reduction, with the high response rate, with all of the primary and secondary outcomes satisfied by the lower dose, 3 milligrams, I'm a little bit more optimistic, but we have to wait and see what the phase 3 will show.
Okay.
I agree with Murray completely. If I can jump in, I agree. And I think what's also interesting, just piggybacking on what Murray just said, and he said this, that all of the key secondary endpoints were met as well, including organ-specific endpoints, right? Looking at the skin in terms of the classy, looking at active joint counts. So I think it's helpful when you see consistency of efficacy across a broad swath of endpoints, the primary endpoint, but then also these key secondary endpoints with the organ-specific endpoints.
Right, I agree.
I have an additional hope with this drug. That is, it's so similar to JAK inhibition, but it had no thrombosis on the trial. So it's kind of a hopeful thing. Moving a little bit, telitacicept. Okay, now it's that. It's the mechanism of action is in the TACI-APRIL, so quite on the same way as belimumab, and it's on the phase 3, so it is promising. When do you think we're going to be able to use it? What do you think about it? And is it going to change the current practice between belimumab and anifrolumab? Murray, what do you think about it?
So when I saw these results, the first thing I said was, wow. And the second thing I said was, I don't believe it. It is so dramatic. We talked about the difference being 20% between placebo and the drug in the previous discussion. Here, the difference is 45%.
Yeah.
And so, and remember, this was done in one ethnic group in the Chinese population. It's a dramatic finding, but I don't think anything can happen until we have another phase 3, which is multi-ethnic, and we can see what the response rates will be. I'm excited, but tempered.
Okay. Maria, do you agree?
I agree.
With it in the current practice.
I had exactly the same response, that this was an incredible response, but then we have to take a step back and say this was done, as Murray said, in one ethnic group, and we have to have the international trial because we know that there are differing responses based upon, ancestry. We know that. But I think it's interesting, right? And we're familiar with atacicept, right, which is a similar mechanism of action. Yes. And now we have a similar type of molecule, this telitacicept. And I think it's interesting, right? And as you said, I think about it as kind of a little bit more exuberant anti-BAFF, right? Because this inhibits BAFF and APRIL, which is kind of the sister cytokine to BAFF. And APRIL, we believe, is important for plasma cell survival. And so that might be one of the benefits of this type of agent targeting BAFF and APRIL versus belimumab, which solely targets BAFF. That is the hope. But I just have to also mention that when you think about the atacicept trials, both in SLE and LN, and that drug, as you know, is still being studied in LN right now, there was an issue with hypogammaglobulinemia, and that's because we think of the effect on the plasma cell. And I think in this particular trial, there were more instances of decrease in IgG and IgM. And so I think we have to look at that carefully, right? Because with increased efficacy, will we see increased toxicity with this particular agent? So as Murray said, we have to continue to follow this and see more of an international trial and look at all these issues.
Perfect. And it was also very good to see the long-term safety of anifrolumab and even the subgroup analysis of COVID. And so we're kind of having more experience with anifrolumab. It was years of studies with anti-interferon, and we now have a drug that we use clinically. And Maria, how did it change your practice in the last year or 2 years? How did it change your practice when you want to choose a biologic for a patient? What are you choosing between belimumab and anifrolumab? Do you have a special patient with special clinical features that would make you choose between one another?
That is such a great question. I think it's a question that we all debate in the clinic when we have a patient in front of us in whom we want to start an approved biologic therapy in lupus. And now we're talking about the non-renal realm, right? We're mostly talking about musculoskeletal and skin manifestations, because those are the predominance of patients that were enrolled, as we know, in the belimumab non-renal trials, as well as the anifrolumab trials. And so I think to get to your question, I think a specific niche of patients in my experience, and also, as demonstrated by the data in the clinical trials in TULIP 1 and TULIP 2, who respond especially well to anifrolumab are the refractory cutaneous patients, right? Patients with SCLE, DLE. And I can tell you that in my personal practice, those are patients that I will tend to move towards anifrolumab. It works quickly. In fact, I just saw a patient in my clinic 2 days ago who was a nurse at our institution. And, within 3 days of the infusion, had remarkable improvement of these very refractory subacute cutaneous lupus lesions. Dramatic response, whereas belimumab has a longer time of onset, as we know. It can take, 4 to 6 months to see full effect. So I think that cutaneous patient tends to be a particular subgroup in whom we may decide to move more quickly with an agent like anifrolumab. That being said, I think both of these biologics have a role in lupus, and I feel so grateful that we have options in lupus finally. As coming back to what Murray said in the very beginning, that we've never been in a situation before. We've had so many, I think, options at our fingertips, and also drugs coming up through development. But I think we're all trying to figure this out. We're trying to understand which patient, which drug. We don't yet have biomarkers that help us in a very robust way. So I think it does come back to clinical judgment, using the data in the trials to help us, but a lot of clinical judgment and patient preference as well. Anifrolumab right now is just IV. Whereas belimumab is IV or sub-Q, and there are some of my patients who just don't want intravenous infusions, right? So then those patients we would move more towards subcutaneous belimumab.
Okay, Murray, a more challenging question. We're talking about a new conceptual disease modification, SLE. We're talking about when to start a biologic, not on the idea that we had that very refractory patients, we do have now new biologics. But if we start thinking about from the very first beginning, introducing a biologic that would change the concept of disease through times, do you think on belimumab and anifrolumab on the same way? Do we have enough data for this strategy? What I told you, it was a challenging question, but I think that you are one of the best person to talk about it in the world.
So you're touching on a very important question, which I think we may even come up to again later. In other words, what's the best treatment strategy for lupus patients?
Yes.
And it's interesting that right now, unfortunately, one of the determining factors is the payer.
Of course.
The person who pays for the drug, and so many of them say to us, you've got conventional therapy. Many patients are helped by it. Try it. If that fails, add in, you can then apply for an additional drug because these drugs are very expensive. So unfortunately, we've been somewhat limited because of those issues. But if you ask me in theory, I believe, well, especially in lupus nephritis, and Maria will know this is better than anybody, you can't fiddle around. Every moment you waste, you lose nephrons, and you've got to start your drugs early. So if I had my druthers, if I really could choose, I would say I would start patients immediately on classical therapy, probably hydroxychloroquine. Aside from the steroid, we can talk about that separately, steroid always a little bit, but the hydroxychloroquine and mycophenolate. And I would start a drug like belimumab. And the reason for belimumab is, number one, we have 8 or 10 years experience with that drug. It's been licensed both for general lupus and for lupus nephritis. And it doesn't work, as Maria said, for a couple of months at least, maybe 3 or 4. And so started at the beginning, you'll start to get your response. Belimumab will kick in and keep your response. To me, that's the ideal. And that's what I'm hoping will happen. It may very well be it can't happen until we get a study showing that starting early, not after refractory state, but starting early is better than not using those drugs early. We may have to look at getting a study. I don't know if that's going to be an investigator-initiated study or whether one of the pharma companies will undertake that study. I think that needs to be done because I think that's where we're going. By the way, lupus is no different than hypertension, than diabetes, than atherosclerosis. Those patients start on 2 or 3 drugs right early on.
Yes.
Now, you don't sit around and say, is hydroxychloroquine going to work for this hypertension or wait 6 months? We don't do that for hypertension. And I think lupus is going to go that way. I think we're going to be combination therapy early. How can we get there? And, either we're going to have to do a good propensity matched review study in patients already on drug, or we're going to have to do a new study showing that starting drugs early is the way to go. That will be my preference.
Yes.
That's the bottom line to your question.
And we need to prove also that financially it's better not to have damage through time than not treating with a more expensive drug from the beginning.
Right. Those studies, by the way, are clear that healthcare facility utilization and damage accrual is much more expensive than the 2 or 3 years of an expensive drug.
Yes. Moving a little bit subject, Maria, do you think that voclosporin will substitute tacrolimus in lupus nephritis? Do you think it works in a different way? Do you think it's a disease modification therapy or just another calcineurin inhibitor?
Great question. So I think that there are mechanisms that are shared among all of the calcineurin inhibitors. Mm-hmm. We know that, right? We know that there are 2 major mechanisms. One is the immunologic effect on T cell activation, differentiation, but the other is a direct effect on the podocyte. And we know that through, preservation of synaptopodin, which is very important for the structural integrity of the podocyte foot process. I think that is the effect that is leading to the rapid reduction in proteinuria. It's the effect on the podocyte, which leads to that rapid reduction in proteinuria that we see with these agents. So that's a class effect, no matter tacrolimus, voclosporin, or cyclosporin. And so I think that what's interesting about voclosporin is it has 5 times the potency of cyclosporin A, and it has less of the metabolic side effects, which I think is very useful and helpful. Yes. It also has a more consistent pharmacodynamic profile, pharmacokinetic profile, such that we don't have to measure drug levels, which we have to do with tacrolimus. So I think that there are benefits. I think you're asking a very good question, though, because I think the major difference is going to be the cost, right? The cost of voclosporin versus the cost of tacrolimus. And do those benefits that I just mentioned around voclosporin outweigh the cost? And as Murray said, it's going to come down to payers, I think. So if I had my choice, and I can tell you what I'm doing now, I am able to prescribe and get voclosporin for my patients.
Okay.
So I am doing that because I think it's just, we have the international trial data. It's approved for the treatment of lupus nephritis. With tacrolimus, we don't have the international data. We mostly have data from China, very good data. But again, we don't have all the races and ethnicities represented. I'm able to get it, but I know that there are plenty of places in the world where they cannot get voclosporin. And my personal opinion is that the same effects that we're seeing with voclosporin are translatable to tacrolimus. And so I think that in those areas where they cannot get access to voclosporin, my opinion is you can think about them similarly and use tacrolimus in combination, just as voclosporin was studied in combination.
Perfect. Just on the research highlights, just the last one, because we would stay here talking about the ACR meeting results, but we only have 30 to 40 minutes. So just trying to finish a little bit of this research highlight, the CAR T therapy that was presented, the results of these 5 patients. Murray, did it ring some bells on you with the excitement, or do you think it's a little bit away from the clinical practice?
Well, it's a long way from clinical practice. This is 5 patients followed. I think the range was like from 3 to 11 months or something like that. Is it exciting? Oh my God, it's very exciting. It's like the bone marrow transplants that have been carried out in scleroderma or in other diseases.
Yeah.
This is a form of bone marrow transplant. The other thing with CAR T is that there are 2 things. The bad thing is before you give the CAR T cells back to the patient, they get chemotherapy. So they have to survive the chemotherapy, first of all. And that's one of the downsides of bone marrow transplants is you got to survive the chemotherapy, right? But once you do that and you get the cells, all the treatment was stopped in these 5 patients. Stopped. They got no lupus treatment at all. And the CAR T cell was so effective, I think it was in 2 days, there were no more B cells. And they stayed away. Yes. And even when they came back, I think it was in 130, 140 days, something like that, the disease didn't come back. Now, this is a very short follow-up,
Yeah.
And it's only a proof of concept type of study. Is it exciting? Wow. Is it close? Not.
No.
It's eons away. Am I happy that someone's working on it? Absolutely. I think it's very exciting.
If you had a very, very refractory patient, would you consider it?
You mean, and I used all of the other medicines that were available?
Yes, currently.
Yeah, you know what? If they're not very common, people don't respond to anything. Yeah. But anyway, if people didn't respond to anything and my center were doing these studies, I only would do it in a center where there's a lot of experience, Yes. And I mean, even preparing those cells is a specialized job, preparing those T cells. So if I were in that kind of center and everything else failed, yes, I would consider.
Yes, exciting. Yes, really exciting. There were also some studies that were presented on current practice and treatment strategies, as Murray, you were saying just a few minutes ago, like the best hydroxychloroquine dosage, tapering, flares, risk factors for advanced kidney disease, mortality. So we were talking about all these exciting new drugs and new strategies, and we are still getting news from the old drugs. And I really think that this was really exciting. And the work from hydroxychloroquine, the works that were presented, this was exciting. After the American Academy of Ophthalmology published some years ago, 6 years ago now, 7 years ago, the revised hydroxychloroquine dosing guidance and lowered it to 5 milligrams a kilo a day. The EULA guidance also recommend this change of dosages, and this was controversial. There were lots of letters coming back to the guidelines. And now this work of the Massachusetts group presented some beautiful work on the risk of hospitalization due to the dosage of drugs and SLE and SLE flares. So, and the SLEEK group also presented the risk of flare, damage acral, and death based on hydroxychloroquine levels monitoring adherence. Maria, what do you think of these recommendations? What do you think of these works presented? What is your current clinical practice on hydroxychloroquine prescription?
Yeah, so these are really important questions, and I'm looking forward to hearing our world expert, Dr. Urowitz, on the hydroxychloroquine. He's done so much work in this area and contributed to literature in so many ways. I think this is very interesting, and it is an ongoing debate, right, in the lupus community. What dose is most appropriate about hydroxychloroquine, and at which phase of disease, right? So I think that there are certain doses that we may use early when the patient in front of us has very active cutaneous manifestations, let's say, or active arthritis, but then 20, 30 years down the road when they're quiescent, do we still want to have them on these higher doses, which we know will lead to retinal toxicity? And that's been shown very beautifully. And so therefore, we know that we have to get patients down over time. How do we do it safely? And when do we do it? And so just to get back to the study that you referenced by the Massachusetts General Brigham cohort, which was the one that you just talked about, where it was clearly shown in a case crossover study that patients that were on that lower dose of less than or equal to 5 mg per kg per day of actual body weight had more of a risk for a hospitalized flare due to lupus than patients were on the higher dose. And they also looked at the 400 milligram cutoff as well and found similar data. I think, those are compelling. What we don't know is what were the drug levels at the time in these patients, and we don't really know adherence, right? I think those were prescribed doses. So I think there's still some work to be done. I think that my personal opinion is that we likely will be using higher doses of hydroxychloroquine for very active disease, and then we have to think about tapering down the dose and getting people off eventually over a period of time, because that's, we know from the Kaiser Permanente data that led to this 2016 change in the American Academy of Ophthalmology guidelines, that after 20 years, about 20% of patients will develop some form of toxicity, even with the less than 5 mg per kg per day dosing. So how do we do that safely, I think is going to be the question for all of us. And I can say that I think about this all the time in my practice. I don't have the right answer, but I think about it. I teach my fellows to think about it. Don't just leave people on these doses for, in perpetuity. One thing that I have not yet done in my center, but we are going to start doing, we're a little bit late to the game in this, is we haven't done blood levels because we haven't been able to get reimbursed for those, but that's changing now. And I think getting blood levels is going to help me better understand, what therapeutic level are my patients getting with this drug, and can I maximize that to the goal of 1,000 nanograms per milliliter, and then when I can start backing off over time.
Yes. Murray, we are waiting for your insight on this.
Maria, bravo. I hear what you're saying, and I think that's the course of action we follow. First of all the hissing and booing after 2011, after 2016 was me. I thought the evidence that they brought forth, retinal toxicity is so uncommon. the evidence they brought forth was very unconvincing. And this study says it doesn't matter which dose you, and I agree with Maria, we don't know anything about compliance here. So we're just assuming people took the drug. But it doesn't matter whether you looked at 400 above or below or 5 mg per kg above or below. In either case, if you were below the level, you did worse. So it shows you need more than 5 milligrams per kilogram, and you need up to 400 milligrams per day. So I think this study showed that we don't know the exact dose. It's probably not 5 milligrams per kg. It's probably higher than that. And so I thought, oh, okay, thank you. And so what do we do? I still give in the beginning, just as Maria said, I start with about 6 or 6.5 milligrams per kilogram. So if you're talking about a 60 kilogram woman, it'd be 130 pounds, something like that. That gives her 390 milligrams, a little under 400 milligrams. So you give her 3.5 pills or 4 pills, whatever. I give her that, and I treat her that way for at least a year or more.
Okay.
And of course, they get monitored for eye toxicity, et cetera, and the other toxicities that we've reported. The QTC interval, the myocardiopathy. There are a lot of things that we can talk about at other times. Now, can you take it away? So in last year, or in 2021, in ACR Open, we published withdrawal. So we mandated that there was remission for at least 1 to 2 years. So you're not talking about taking it away just because they're taking hydroxychloroquine, but because they are in remission. And we showed that abrupt cessation was bad and slow cessation was good. And why is that? Because with slow cessation, you end up giving it for a little bit longer or quite a bit longer. Mm-hmm. So that's our plan. I start higher, around 6 milligrams per kilogram. I keep them on that until I feel that they're in remission or close to remission. I keep them until they are in remission for a minimum of a year or two. And then I do a very slow withdrawal. Slow meaning 1 pill every 3 months or something like that. So instead of 7 days a week, they take it 6 days a week. And then I wait 3 months, then 5 days a week. So it really takes them another year and a half to get off altogether. And so you've got to balance the potential long-term toxicity and the wonderful positive effects of the drug.
And you do take them off completely?
Yes, I do try.
At some time?
Yes, I do try. And if you look at that same paper, those people who stopped, and some stopped because of early signs of toxicity, or some stopped because they felt so well they just didn't want to take it anymore. If they flared and went back on, the vast majority recaptured.
Yes.
The vast majority. So that's another positive outlook.
And we are talking about tapering hydroxychloroquine. And another study from the Asia Pacific centers published the risk of lupus flare while tapering treatment when lupus patients were in LLDAS or complete remission or clinical remission. And they did a complete study with all the drugs. They did a study while they were tapering steroids, while they were tapering immunosuppressives. And there was some results about the risk is less if the patients are in complete remission. And it comes with the kind of thought that you were talking about hydroxychloroquine. So I'm going to start with Maria. What do you think about this study? What do you think about, of course, the huge number of patients. What do you think about this tapering? Yes, please, Maria.
Yeah, no, I think that's a great question. I think this exactly it flows from what, Murray just discussed and what his practice is with hydroxychloroquine, that he doesn't just stop cold turkey, he tapers over a course of time until it comes off. And I think in this particular study, they also tapered. I think it was a quicker taper for the purposes of this, when they looked at this, of these patients. But they also showed, as you said, a similar idea that patients who were in what is called a complete remission, which I believe is a SLEDAI of 0, which means no serologic activity even for complete remission, those patients did better. They had a reduced risk of flare compared to those who were even in LLDAS, for example, because they were trying to compare these different targets, right? LLDAS, complete remission or clinical remission. And so I think it just goes along. And I think with what Murray said, and so I think it's interesting. So I guess the concept here is, we can't keep our patients on these medications forever, right? Yes. There are various reasons why people are going to have to start coming down on these medications, either toxicity, perhaps pregnancy in the situation of something like mycophenolate or methotrexate, where they can't be on these medications and get pregnant. Or perhaps we're just worried about, long-term toxicity 20, 30 years out. So the question is, how do we make this actionable in our clinic? How do we advise our patients? How do we think about it? I think the theme here is you want your patient to be in a state of clinical or complete remission, however that's defined, for a period of time, and then you go slow. You start to taper. You don't just stop, but you taper and you follow that patient carefully. And as Murray said in his publication, patients were able to regain their state of clinical quiescence even if they flared, right? Because you're not just going to taper people off and send them home. You're going to follow them in your clinic and you're going to look for symptoms or signs of flare early so you can reinitiate therapy.
Murray, let's think of a patient that is in clinical remission with belimumab, for example, and MMF and steroids and hydroxychloroquine. Which were the first that you would try to taper off?
So thank you for that. And let me start off by saying that's my major criticism of that article. They said we started to taper therapy. Well, which one?
Yes.
It's a very important question. And I'm sure tapering steroid versus immunosuppressives is different, and might have different outcomes. So it was hard for me to get the bottom line of that paper. Now, in answer to your specific question, which is you've highlighted the downside of that paper, the first one I want off is steroid, without any question, right? And my general approach is when I start to treat the patients, whatever dose I treat them with, I'd like to get them down to around 7.5 to 5 by 3 months if I can.
Yes,
right? Some go a little bit longer, but try to get them down. And then they stay on that dose until they've been in remission for some period of time. And then the first drug that I start to wean is the steroids. And so we published that also, right? The steroid withdrawal on patients. If you do it slowly over a period of time, and the patient has been in remission for at least 2 years, you can get off steroid altogether. Even 5 milligrams is worth getting off. Michelle Petrie has certainly shown that early on, some time ago. So steroid is the first. Then you're asking the other drugs, The first thing I would say is if you have lupus nephritis, they've got to stay on some form of immunosuppressive therapy for 3 to 5 years. That's now a EULAR guideline.
Yes.
That's now clearly and accepted by everybody. So I wouldn't rush that, right? Now, you may be able to reduce the dose. If they needed 6 grams of mycophenolate to get the remission, you may be able to bring them down to 4 or 4 pills or 3 pills, etc. Yeah. But on immunosuppressive, and we've shown that also in our studies now, and so I'd keep those on for at least 3 years. Now, what about belimumab, right? What if they're on that drug, was started on that drug? And there, again, I would like a remission for at least 2 years, if possible. And then what I would do is start decreasing the drug. Now, with belimumab, if you're on sub-Q, which many of our patients are now, instead of doing it weekly, you could do it every 10 days or every 2 weeks and do that for a little while and see if that helps. It doesn't cause deterioration. And then you can stretch it out every second week or every third week, etc. That would be my approach. There's not yet a well-established approach because we haven't had a withdrawal study yet. in patients with belimumab. So I would start reducing when they've been in remission for 2 years, but I would drag it out, reduce it slowly.
And would you still reduce the dose of hydroxychloroquine during this time, but keeping it just not as high as it should be?
Right. I never do two things at once, because then you don't know what the issue. Make your decision which one of these you want to reduce, and go with that and give it time and then do the other one. And it depends how long. If they've been on hydroxychloroquine for a long time, you may want to start reducing the hydroxychloroquine first. But I would only do one at a time, because if you have a flare, then you're in real trouble.
You need to know where you are.
Exactly.
We had so much more to discuss about the ACR highlights, clinically even, the all-cause mortality in SLE, the risk for advanced kidney disease after a lupus flare. This was really exciting. I think that whoever is listening to us should go to the leaflet on the site to see the resume of these. Maria and Murray, thank you so much for joining me today and sharing your insights. I really feel that this was an exciting discussion. To our listeners, we hope these discussions have helped you gain more of an understanding of lupus. Please download the Lupus Academy's ACR meeting highlights report for our website, a link that can be found in the show notes. We are very happy to be able to tell you a bonus episode will be released on the 5th February with our review of all exciting developments in lupus in 2022. Thank you so much for listening. We hope you enjoyed this podcast. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world.